welcome everyone. This is House Healthcare, April 22nd. And we're continuing our work on S126. And today we have in with us, specifically, we're talking about sections 8 and 9, which have to do with a statewide, I'm really sorry, I can't remember the name of it. I'm sorry. Statewide healthcare delivery plan. And first we have with us Christopher Kohler from Milbank. And welcome back. We had joint testimony, I know, with Senate Health and Welfare with you earlier in the session, but it's nice to see you back. Thank you.
Thank you. It's great to be here. Is that a handoff to me? I'm not.
That's a
I'm not
handoff
sure
to you.
your
I
protocol.
didn't know if you had. I didn't know if you had slides that you were.
No, I don't.
Going out.
I only got reached over the weekend,
Okay.
so I apologize. I don't have slides. I will. What I have is a set of notes for myself, and then I will try to put a little bit more text with them, and then share them with the committee members.
Yeah.
So,
Okay.
and I understand that we're going to go for. You tell me. I think I heard like 30 minutes, all some combination of testimony and discussion. Is that about right? I'm at your service, so just let me know what the structure is.
30 minutes would be great, but if it goes over, then it goes over, and that's fine too. We have all the time you need. And, I think that as we're thinking about what we are looking for in a statewide healthcare delivery plan, one of the things that we're really interested in is primary care. Primary care is really struggling in our state right now, and it seems to be sort of the foundation, and the foundation appears to be crumbling a little bit. So we really want to get your expertise just sort of around that and any other thoughts you might have as we're developing this.
Okay, well, I've got a set of remarks, but feel free to interrupt at any time. I don't, it's one advantage of your intimate setting. I've been in that committee room, is it can be really conversational. I'm sorry I can't be there, but by all means, just don't. I'm not sure I can see you on my screen. I have you reduced so I can see my comments. So please speak up at any time with questions.
Will do.
So thank you very much. Just to remind folks, the Milbank Memorial Fund is an operating foundation. Our mission is to improve population health and health equity by collaborating with leaders and decision makers like you folks and connect them with evidence and solid experience. It's been a privilege to work with states in general, and particularly with Vermont. I've been doing this work at Milbank for 12 years. Before that, I was the Health Insurance Commissioner in Rhode Island, where I regulated commercial health insurance to a set of standards around affordability. And before that, I ran a Medicaid health plan in Rhode Island. But we think public service is really important, both in the executive and legislative branch. We think you need a range of folks working together on this to help ensure the welfare of everybody, and appreciate the work that you folks do in your role and in the legislature. So I was glad to hear those opening remarks, because that was my understanding too, was that I was to comment on sections 8 and 9, and that's what I'll be talking about. It is a very important and a very ambitious bill, and I appreciate the leadership of the legislature in bringing it together. I would just want to underscore it's really important, particularly at this stage, because as healthcare grows as an industry, I think legislators, elected officials in particular, are caught between the two dual roles of healthcare. It is both a source of expense on state budgets and individuals, but it's also a tool for economic development. It's been a major employer, and squaring those two is almost impossible, but it's really the dilemma that we have to do, particularly when the evidence is that if we're concerned about improving population health, which is what Milbank is about, and health equity, more money in healthcare doesn't really do it. There's pretty good evidence that money would be better spent on education, on social welfare, given back to individuals than spent in healthcare. But yet it's jobs, and that's what we recognize, and it's also local institutions that people are proud of. The other reason why this is important is our current federal environment. It's my own interpretation that we're going through a really drastic rebalancing of what federalism means, the balance between state responsibilities and federal responsibilities. My own opinion is that this delegation to the states is not going to change even with a different election. The states are going to have more and more responsibility over these public welfare questions going forward, in part because of the expense of healthcare. It really is. Put away the ideology, healthcare is a larger and larger part of the federal budget, and they can't afford other obligations, whether it's reducing taxes or funding the military. So it's part of the reason why it's not the only reason, but part of the reason why more and more responsibility is going to the state is to figure out what to do with healthcare. So I want to begin I apologize if this is a little academic, but I'm going to give my attempt at understanding the problem that we're trying to solve in sections 8 and 9. I think there are two, and I may be wrong, but it's always helpful to make sure we know what problem we're trying to address. I think one of them is guidance, both general and specific, for administrative agencies, notably the Green Mountain Healthcare Board and the Agency for Healthcare Services, as they make resource allocation decisions. Kind of how do we allocate scarce resources? And the thought is that a plan would help. And I think the second need that we're trying to address is what resources are needed to monitor the Vermont healthcare system, to generate objective performance goals and then to measure performance relative to them. I think those are the problems. I'm not sure they are, but and you can, maybe in discussion, we can see if we're working on the right problems. I think section 8 gets at the first one. How do we give guidance to public officials as they make resource allocation decisions? And section 9 is about the monitoring. How do we get resources for monitoring what's going on? Our role at Milbank is, we are not experts in any one state, but we are aware of what's going on in other states, and I hope to bring that experience to you folks. And I've got bad news and good news in that order around these two problems. First, the bad news is that while a comprehensive health planning function that gives really specific guidance for resource allocation decisions is called for, especially in smaller states. In Rhode Island, I had that all the time. People would say, we need a plan. We need a plan to figure out what to go on. And the most obvious one is how do we make hard decisions around local hospitals, which is particularly an issue in Vermont, but it's an issue in Rhode Island as well. So while a planning function is often called for, particularly since the collapse of the planning function in the 70s, when it was these broad health systems agencies were in place. I'm not aware of any state that has an effective functioning plan right now. So it's important to understand that there is what's being proposed in section 8 would be new territory. In some ways, it would be back to the future, in that it would be trying to rebuild some of the capacity that was disassembled in the 70s. And you may find this of interest or of concern or regret. But when in preparation for this testimony, I asked around for who has good planning, and without knowing why I was asking, people said, well, Vermont does that pretty well, don't they? So there is an external perception that Vermont is clinging to the old planning, the historical planning functions. I think in part that's created by awareness of the Blueprint for Health and the Green Mountain Healthcare Board. So
can I interrupt you really quickly? Because you said something, you said the dismantling that started in the 70s.
Right.
So can you speak more to specifically?
Sure. And probably it was the early 80s, actually. I apologize. I was kind of glib. There was in many states a very conscious health system planning capacity funded by the federal government and often supported by the state. And they tended to be not it might be at the state level or it might be at the regional level. They were called health systems agencies often. And they were often connected with rate setting, setting hospital rates, a public rate setting process. And they were disassembled in the, I said 70s. I'm not a historian. It might have been early 80s. The real sort of momentum came with the election of President Reagan and the deregulation phase. So it was part of a broader deregulation, including healthcare. The idea that a market economies could allocate resources more effectively than government planning could be. And I part of me would love to go back to those days. I think it is very hard. If it was hard to plan for 5 or 6% of the economy, which is what healthcare was back then, it's really hard to plan for 17, 18% of it now. So kind of what do we do given that, if we can't put the genie back in the bottle, how do we deal with it? Is that helpful?
Yes, thank you.
Okay. So what can be learned if we can't put the genie back in the bottle? And maybe we can, but how are state policymakers making these resource allocation decisions? And I'm just going to, again, this is just sort of my summary of what's going on. I'm going to try to state some state examples. One is just simply neglect. They're not facing up to it. And I think that's more possible in geographically larger states, frankly, where there is less of a frankly, there's less tight civic relationships, so there's less attention to the plight of these providers. So there's a hope that just competition, market competition, will take care of it, or commercial will subsidize, which has been happening a lot. That what Medicaid and Medicare doesn't pay for, commercial payers will just pay for. I think that's less and less the case now as employers realize what's been going on. Not so popular in the East, but in some places you have had regional health districts, much like education, where the taxing authority was given locally and they support either in part or in part because there would be Medicaid and Medicare, but there'd be some local taxing authority to support local entities like with education. More kind of, I would say, newer innovations are really, this is around, again, if we don't want to say, I'm going to be crass here, who lives and dies, you put in place you put entities accountable for budgets, and they make the decisions around allocating the resources. A good example of this is what Oregon does in Medicaid with their coordinated care organizations. It really was what was behind your OneCare experiment, was to have an accountable entity that would make these resource allocation decisions. And you lived through that, and I'm not gonna go through the autopsy for OneCare, but it's worth understanding at least that was what was behind OneCare. But we're doing it again. We're thinking about that. Some of the thinking around ahead is you have a global budget that is price and utilization for all the services an entity uses. That was and you make them allocate the resources. And in some ways, whether it's OneCare or whether it's the HEAD model, it's trying to bring that more to the delivery system and not just to insurance companies. Because when we put insurance companies in managed care responsible for that, they often make utilization review decisions that make people angry. So the thought is to try to get it closer to providers. And you can think of a HEAD as kind of I've never thought of this before, but almost like accountable care plus planning, because they want Vermont and Maryland and the other states are being asked to, yes, have accountable care in place with these global budgets, but also do some planning around how do you strengthen primary care, how do you address social determinants of health and things like that. Another example of how states are making resource allocation decisions are not to get specific, but to have you folks as legislators really try to say, these are our priorities. This is sort of, we want to see more of this and less of this. And I think you actually did that 10 or 15 years ago in the Blueprint for Health. You put money behind and you gave state authority to really try to rebalance the healthcare system. You didn't put the population constraints around it, but you really tried to build up primary care on the thought that that would have long-term benefits. We did that in Rhode Island with our primary care spending, where we just told the insurers to rebalance their spending and spend more on primary care. And that's been, I would I'm grading myself, I would give us like a B on that. I don't think it's gotten all the way through. But often, and I thought of this as I was getting ready for this testimony, a really good example actually is what's been going on with nursing homes. How we have over time tried to reduce our dependence on nursing homes and have more community-based care. And some states have been particularly successful at that by not only creating more um, uh, uh, community-based alternatives for long-term care, but also constraining hospitals. I mean, excuse me, constraining nursing homes through bed limitations, certificate of need, and things like that. And I haven't really thought about it before getting ready for this, but I wonder, obviously, hospitals are much bigger entities than nursing homes, but I wonder if there's some lessons from rebalancing long-term care that could be applied to acute care. And then finally, the last example, and this is indirect. If we can't have a plan, think about the institutional leadership of these institutions that we care about. And frankly, how do we expand the responsibility of these leaders to think not only about their institutions, but about the public that they are serving? And I know, for example, when I became health insurance commissioner, the same law that created my position also created public appointees to the board of Blue Cross and Blue Shield because of some concerns that the legislature had around how they were governed. And it's really had a profound effect on how Blue Cross and Blue Shield has acted. I also see in other states where publicly chartered academic medical centers and private academic medical centers are side by side. The public chartered ones behave in a very different way. So thinking about that accountability of these institutions, whether they're small, like the hospitals, or large, like academic medical center, to you folks. And the most obvious way to think about that accountability is public appointees to the board. So, and I'm just finishing up on section 8 here. I think I'm not sure I would encourage, or at least there's not a lot of support from other states around highly technical, very focused, specific planning. There is support for kind of a more general, more than encouragement, but sort of an expectation of rebalancing towards more community-based care that you can give to AHS, to public employees, to the Green Mountain Healthcare Board. I would note that you have one of the highest portions of your citizenship in the country that is served in community health centers. I thought we were high in Rhode Island because we're 1 in 5 get their care through a community health center. You folks are 1 in 3, and that's a really strong basis, chassis for doing this community-based care. And no one from Bi-State paid me to say this. I just think you build on what your strengths are, and you have a very robust, strong community health center delivery system that can be the basis, not for everybody, but for a lot of folks going forward. I do think there are opportunities to look at the blueprint again and frankly raise it to a level of prominence. It's become, at least by my observation, in spite of committed management of it within AHS, its aspirations are smaller, I would say. It's become a way to support certain staffing positions. And I think it can do more for that, particularly if you send a strong signal that we really do want to rebalance our delivery system. I would encourage you to think about public appointees. And I know there's been a lot of debate, public employees to institutions, excuse me, and the accountability of these entities to you. And then I think there's something around ahead. I mean, and I know it's difficult, and particularly with the changing federal environment. But I think if a state, it's so much easier to do this work when you have Medicare aligned with you. And that's really the core of the ahead opportunity, is to get Medicare sending similar signals to what Medicaid and the commercial insurance has done. So those are my comments on section 8. And then I want to talk a little bit about section 9 as well. Do folks want to pause there, or should I just motor through?
Yep. I think we have a couple questions. Topper has a question.
Yeah, thanks for coming in. Could you just talk about social determinants of healthcare? What's
Sure.
meant by that?
Yeah, I'm sorry. I raced through that. The idea of social determinants of health is that much of what helps you and me live long and happy lives really happens outside the doctor's office or the hospital. It has to do with our education. It has to do with our housing. It has to do with our environment. And there's really good evidence around that. So how do we, so those are what they think of social or societal determinants of health, how good my diet is, whether I can exercise. And so if we want people to live long and happy lives, we have to act on that evidence and figure out how to support good, strong schools that educate our kids, good housing, not and in some ways, not in some ways, those can be more cost effective in the long run than what we spend on healthcare.
Thank you.
Leslie has a question.
Yeah, thank you. I'm not sure if this is section 9 or section 8, but I'm curious to know who enforces the plan. Should we be able to come up with something? How does it get
Well,
enforced?
I think that's a really good question. Historically, back in the 70s, the plan was enforced really through the department. I don't want to speak to Vermont, but just in generally through certificate of need laws. So hospital would come up and say, we want to do this. And someone would, well, let's pull out the plan and see if it corresponds with the plan. A more, I think, active way, frankly, hitting people in their pocketbooks is through the rate decisions that the Green Mountain Healthcare Board would say. If they could, and I've been there, when they have to make their decisions, they have to be the bad guy. They have to say yes to these people and no to these people. And it would be good if they could point to something to say, well, they told me to do it. They told me I got to spend more on primary care. I want to spend more on community-based services. So therefore, I can't give you hospitals everything that you want. The really hard decision is what happens when an institution says, I'm going to go bankrupt. That's really and that was what the storm that was created by the planning document that Green Mountain Health Care Board commissioned is talking about particular institutions not surviving in their current form. And that's why I'm so interested in, as I was getting ready, how do we make these decisions around nursing homes? Maybe they're easier for nursing homes because they're smaller or they're for profit, but we've had to do the same thing. We've had to shut down nursing homes or make them smaller or repurpose them. And can we do some of the same of that with our healthcare infrastructure?
Is that Leslie? I was wondering, you were talking about Rhode Island's model. You gave it a B, which frankly, a B might be pretty good right now.
I'm not sure everyone in Rhode Island would give it a B. They probably feel like it's a C. Maybe I'm an easy grader. I'm sorry.
Can you
go ahead.
well, we hear about Rhode Island a lot. Can you sort of explain to us, since you were there, what the model is around primary care, and how they implemented or enforced that, and what its effects have been?
So the focus in Rhode Island has been on commercial insurance, which makes sense because Medicaid, you set your own rates, so you can control that a little bit more directly. And Medicare, we have no control over Medicare. That's a federal program. And so what was unusual about Rhode Island at the time was it directed the insurance regulation to not only regulate to solvency and consumer protection. So that's what I had to do when I was commissioner, was to make sure that the insurers are solvent and the consumers got the what was promised in the contract, but to regulate to affordability, to direct, and this is from the statute, to direct health plans towards policies to improve the accessibility, affordability, and quality of the system. And so that created another obligation for the health plans, that they had to improve the affordability of the system, not just of their own policies. And so we actually, with the help of one of your own, I guess he's a legislator now, Herb Olson, but he was our counsel for a while. So Herb's got a lot of experience with this, put in place a set of regulations that said to the insurers, you have to help us rebalance the system. The evidence says that a system that is doing more primary care, preventive care, is better in the long term. It's more cost effective. And so we are, and we understood that part of the reason why we have such an institutional-based system is because of the strength that hospitals have to negotiate their own rates. You know, when I've been there, and in the end, people they want to make sure the hospitals stay alive. So hospitals with negotiating leverage got rates higher than inflation, rate increases higher than inflation. And so we sort of acted as the office acted as the bad guys and said to the health plans, you have to rebalance your spending. You have to spend more on primary care and give lower rate increases than you have been giving. In this case, we said inflation, to the hospitals. And so over time, there has been a longer term rebalancing of where hospitals have not gotten everything that they were getting. You know, that previously they were getting 6, 7, 8% rate increases. It's sort of a lighter version of what you have in place in Green Mountain Healthcare Board. You have all those levers. Because you not only have health plan rate review, you have hospital budget review, and that's very powerful. So I think Green Mountain Healthcare Board, to their credit, is trying to do everything and more because you've given them significant authority. Maybe you could give them some direction so that they know how to use that authority to say, Green Mountain Healthcare Board, you must have primary care be this portion of our delivery system in a given year. That's a pretty crude way to think about remeasuring. But I would say Rhode Island has a lighter form of authority than what you have given the Green Mountain Healthcare Board.
Can I just ask a follow-up on that? And then I think Leslie has a question.
Sure.
Just you know, and as we've been taking testimony on this, and you said something in answering this, you said make it more cost effective. And I'm wondering, this question I keep swirling around is more cost effective for whom? As far as like investing in primary care, investing in preventive care, have we become too successful almost in a way in Vermont, in that we're investing so much when people are younger and healthier to make them healthier in the long run, that we're actually saving money for Medicare and not saving money for the rest of us?
That's interesting. I'm not aware of data that says that people in Vermont live longer than other places. I'm not aware that your Medicare utilization is cheaper than other places. I have seen data from Dr. Fisher, who you're going to hear from, that says that your commercial prices to hospitals are more expensive than other places. So I think data is pretty clear that commercial insurance in Vermont is more expensive than other places in general. And the reason for that is not that your commercial population is using more services, but you are paying more for each of those services. And that, I think that's a challenge for the Green Mountain Care Board. And it could be in part due to you don't want to say no to community hospitals, but it also could be, and I'm not an expert at this, I know Dr. Fisher has presented some information about the cost structure. You know, prices are a function of cost. So I think from an affordability standpoint, I feel pretty comfortable that you have a price issue, not a utilization issue in your commercial insurance.
Thank you, Leslie.
So I heard you say that our regulation is maybe more robust than Rhode Island. I'm wondering if there's language in Rhode Island or in Rhode Island rules that might help us translate into this bill, if that question makes any sense at all.
Yeah, you've got language in Section 9 that calls for setting overall targets for growth. And I think that's an important place to go. I think, frankly, I mean, this is very, we're in a small room, so I'm just sort of puzzling through this and just sort of being very frank. What can you do to strengthen the ability of the Green Mountain Care Board to say no, to be stronger about the need to rebalance our system? And that's very hard because when you say no, people get angry. They think they deserve these services. It means that certain services no longer exist, or that people don't get hired. And it is, it is, that's very hard for a regulatory entity, and it's a little bit easier for a private entity that has to cut costs. They have to make those really hard decisions. But I think from your standpoint, what can you do to strengthen the hand of the Green Mountain Care Board to say no to entities that either have a lot of public sentiment or a lot of political power?
Well, I guess my question is, if I may, is that in the bill or is that in rule?
I think it's got to be in the bill. I think you've got to put, that's a great question. Or you've got to give the Green Mountain Care Board the ability to set rules that can't be challenged in law. That mean, they can't be challenged in court. Because whenever we did rulemaking, my lawyers would always say, we got to do this in a way that we don't get sued. We don't want to go to court. Or if we go to court, we want to have a really strong case. So, what we did in Rhode Island was we referred to, we told the insurers, this was by rule, that they could only give hospitals price increases equal to inflation. They just couldn't go above inflation. And that was a bit of a risk. But politically, we thought we would have the support of employers because they would say, well, yeah, that makes sense. Why should hospitals get any more money than I get, when I'm trying to sell goods? And it stuck. So how do you, maybe Green Mountain Care Board has some ideas, but how do you give them authority, either in law or the authority to set rules for things, for constraints that will stick? And you have language in Section 9 that gets to that because you have that the board or commission that you're establishing set cost growth targets. We at Milbank have had a lot of experience with states setting growth targets. And the problem with those is that they're non-binding. So every year you blow through the targets and people kind of shrug and say, oh, well, we had a pandemic or pharmacy prices went up or something like that. How do you set these budget constraints that are much firmer, that force allocating scarce resources so that getting more money is always an easier option than saying no and laying people off or shutting down services or closing institutions? And how do we make that less easy, frankly?
Thank you.
Thank you. Did you want to talk about Section 9?
Yeah, I think there's a lot of evidence to support what you're trying to do in Section 9. That's whereas Section 8, you've got, there aren't a whole lot of other states that have followed that example. Section 9, there are a lot of states that are doing it. And probably the ones that are furthest along the path are Maryland and Massachusetts. But we work with 5 states that are building up their state analytic capacity. And what they do is these commissions look at trends, price trends across all payers. So they don't just look at commercial, they look at the system as a whole, and they say, what's happening to affordability? And what are the drivers of affordability? Is it in a particular payer type? And is it because we're using more services or paying for each, and which services are it? It's remarkable how consistent it is that it's always commercial that is rising too fast. So if that's any consolation, Vermont is not alone. And it is always price for hospital outpatient and for pharmaceutical. It's not utilization. It's not the increase or the decrease in affordability. The increase in unaffordability is because of commercial prices, particularly in hospital outpatient and in pharmacy, not in primary care, which is where we really need it. That's why we keep talking about rebalancing. And so what Section 9 really tries to do is to build your analytic capacities and a public consensus for the results, for the evidence, so that people kind of buy into it. And some states do that within their regulatory entity. So they do that within, you could do it within Green Mountain Care Board, you could do it within AHS, and some people establish it as a separate commission, like Massachusetts. They have a whole separate health policy commission. So does California. You know, I think smaller states ought to look at not establishing more infrastructure in new places, but how do you add to the infrastructure and build the capacity of your existing places? So Rhode Island, they're doing all this work within the Office of the Health Insurance Commissioner. They are not building a separate agency, but they had to make a decision. They had to sort of say, do we build it in our version of AHS, which is the Executive Office for Health and Human Services, or do we build it within our commercial insurance regulatory entity, which is, I guess, is kind of close to your Green Mountain Care Board, although in Rhode Island, we don't regulate hospital budgets the way that you do. So I think this capacity building in Section 9 is really good. I might encourage you to not try to establish a separate constellation, if you will, but really kind of build it within one of your existing entities, which can be politically tough because that means you're making hard decisions about what existing entities get resources. But there are states that have done it both ways. It's really important. I would think of it in terms of the goal of affordability. The challenge, though, for all these states is, okay, they measure how they're doing, they identify what the cost drivers are. What do you do with that information? How do you make it stick? And that's actually what Section 8 is trying to do. And that's what Green Mountain Care Board is trying to do. So how do you build a bridge between what you're doing in Section 9 and how that information is acted on by, in your case, Medicaid and the Green Mountain Care Board, because those are your two implementation arms. So Section 9, you want to make sure that what their findings are acted on, implemented by Green Mountain Care Board and AHS. And if it's done right, I think they'll welcome it because it gives them frankly, a bad guy or authority to point to say, I've got the evidence. You know, hospitals, don't blame me. I've been told to do this, and it gives them cover, if you will, for saying no, because often that's what this is about. So I think there's a lot to work on in Section 9, and you've got a lot of. I'm sorry, I know it's helpful to you to have specific changes. I'm not at that level of detail. But I think, unlike Section 8, there's a lot of evidence from other states to build on to improve it.
Leslie, did you have a question?
I do. Thank you yet again. On page 19, line 6, they're saying excluded revenue, and you may not know this level of detail, so I'll find it out elsewhere, but exclude revenue derived from hospital investments, primary care, mental health, substance abuse, et cetera. Do you think that's a good idea?
No, I saw that too.
Yeah. Yeah.
I think again, maybe it's because we're in a small room. I saw that as someone in hospitals trying to sort of get credit for their primary care stuff. I think when you focus on primary care, and hospital, well, maybe this is the reverse. When you focus on hospital spending, you've got to focus on all hospital spending. You can't carve out specific categories. The way for hospitals, if you will, to get credit for what they do in primary care or mental health or substance use is by a positive incentive around, okay, statewide, we want to spend more money on primary care, mental health, and substance use. I caught that exclusion too, and I didn't see what purpose that served.
Thank you.
Upper.
I have a question. I can understand how we can control the cost of services, healthcare services that we provide. But I'm struggling with how we can control the cost of healthcare overall if we have no control over the companies that supply the drugs, companies that supply the hardware to hospitals and other service delivery within the service delivery system. How can we do that?
I think your Green Mountain Care Board authorities give you pretty good some pretty strong levers around hospitals. They will say that I understand why. They say, well, we can't control labor markets, so we have to pay more to nurses. We can't control some of our, what you're talking about, kind of these inputs. And I kind of, maybe because I haven't worked at a hospital, I don't have a whole lot of sympathy for that. I kind of say, we've got to live within our budget. So we have to figure out a way to do that and go, this is me saying as a public official, don't ask me to go in and tell you where to find savings. All I know is that this is all I can afford to give you. It's kind of like what I think the legislature does with education. You give it to the schools and you say, live with it. And every once in a while, maybe you've got to make there are extraordinary circumstances. And so you have to depart from that. But think about how we fund our school system. And maybe we don't do a great job with it, but we give them a lump sum and we say, go deal with it. I think pharmacy is harder because that is outside our control locally. There are signs that some states are getting more aggressive about what they call prescription drug affordability boards, where they're trying harder to set prices for drugs. There are those sorts of resources. That's not what we're holding the hospital accountable for. That is something that requires some federal cooperation on. Fortunately, I mean, I think that pharma's that's starting to weaken a little bit now that Medicare is setting prices for some drugs that it's like the nose under the tent. But your concern about drugs is legitimate and is outside of sort of state level control. I wouldn't say so much the same about hospital costs.
Any other questions? So you were talking about, and I keep going back and forth a little bit. If you had, so section 8, we're asking the Agency of Human Services. And then we have the advisory board in section 9, which I'm not sure where that's housed. I don't think it's housed anywhere. I think it's independent. If you had to put the task for a statewide healthcare allocation plan, if you had to house it anywhere, and we have our Agency of Human Services, and then we have our Green Mountain Care Board. If you had to house that somewhere, where would you house that? Whose authority?
That's the $5 million question.
That's why I'm asking you.
Yeah, I think, and you try to do it, make these, I will tell you the reason why Rhode Island, so where Rhode Island put it was in their commercial insurance regulatory, sort of a smaller version of the Green Mountain Care Board. They didn't do that by statute. They did it because of leadership within the Office of the Health Insurance Commissioner, not me, long after I was gone. who just went and they're not acting under statutory authority. They have just built up the resources to do this sort of work through a combination of grants and some state allocations. But they did it in a collaborative way with the Office of Health and Human Services. So they're actually, for some activities, they're actually getting a Medicaid match on it. I think if I was starting from scratch, I would put it in the state health and human services, your AHS, for two reasons. One, it keeps it distributes power. So your regulators, the people who set the budget, the people who are determining rates, are not the people who are monitoring. There's something to be said for keeping the monitoring independent from the implementation. And the other is much more practical, which is that if you're crafty, you can get Medicaid match on some of the analytics if it's seen as a Medicaid piece, so you can get some federal drawdown, which is pretty nice, for just from a budget standpoint.
What about the converse of, as part of the administration and who also administers the state Medicaid program, that it would be forever contingent upon an appropriation?
Yeah, I mean, the reason to put it, other states have, well, actually, some are financed with a direct charge on insurers. I mean, where you go out and you put a tax on either providers or insurers or something like that as a way to finance some of these analytical activities, as opposed to doing it through general revenue. You could build an argument that if you put it in Health and Human Services, you have implementers in Medicaid, and so in effect you don't have separation because you just have a different you're linking it to a different implementing arm, Medicaid, as opposed to your hospital budgeting and your commercial insurance regulation. I just don't, for a state as small as Vermont, I think you seek administrative simplicity, and creating another center of gravity someplace else, it just creates more boards, more commissions, more places for confusion. I'd go make a decision and kind of whatever you do, know that it won't be perfect, so you'll be revisiting it in 3 to 5 years, or your colleagues will be in the future.
Tupper.
I'm going to make a statement, and then you can tell me if I'm right or wrong, I guess. Listening to what you just said, putting like monitoring in the Agency of Human Services and the rate setting in the Green Mountain Care Board, I can see that, I can understand it, but what I don't like about it is the Agency of Human Services monitoring themselves.
Right, exactly, right. And by the way, Senator, I'll never tell a legislator that they're right, that they're wrong. I'll always say that's a great idea, and sir. No, that's the problem with putting it there, is that you're asking Medicaid, in effect, asking Medicaid to monitor itself. But I think in a small state, you've got to be very careful about administrative duplication. If you had an Office of Economic Development that does this for labor and workforce and things like that, I suppose you could develop that kind of analytic muscle there, completely outside of healthcare. That would be kind of an interesting way to do it, because you'd be looking at the economy as a whole and sort of where it is. So if you have if you have capacity in your state that's looking at what are our economic drivers, I suppose you could put the healthcare analytics there as well and not make healthcare its own thing. I'm not aware of another state that's done that, but there's no reason why you couldn't. And it might be good to kind of get people who aren't so invested in healthcare just to sort of kind of look at it more objectively.
Okay.
Yeah, sounds like a good idea. Get them out from under anybody that can influence them.
Right.
Looking at it from a different perspective altogether.
Right, if you have a Department of Administration or I would, the disadvantage there is that, well, it would take a lot of work to get a Medicaid match for that. It is possible if you can have some sort of a cooperative agreement. Um, uh, I- yeah, I'm just thinking through. I think what's really states with larger populations can afford to have kind of more checks and balances and distribute it more widely. I think you just, in a small state like Vermont, you want to do it thoughtfully.
Thank you.
Daisy? I'm not sure if Topper, you were specifically talking about Medicaid, but I'm curious your thoughts around the involvement of the Vermont Program for Quality in Healthcare. There is a section, they're an independent organization, and there is a section on them working in consultation with the board to utilize mechanisms to measure hospital costs, quality, and access in alignment with the statewide healthcare delivery plan once it's established. So I think that section, I'm curious your thoughts on them sort of being that analytic arm.
I've heard of the Vermont Program on Quality in Healthcare in the past. I'm not familiar with them now and how they're set up. That could be an independent arbiter. It sounds like, I guess you were referring to the language that you read is new for them. It's not existing. So you'd have to look at where they're established in statute now and think about changing what their capacity and just their charges, kind of why they exist. So that would be another, like a third place, like what we're just talking about, the Department of Administration, Economic Development, sort of a third place to put it.
Yeah, I think that actually aligns with what their role is in the state.
Yeah. But I do think that you want to, wherever you put it, you want to build a bridge for the Medicaid and the care board to act on it, to sort of, so that they're not just putting recommendation, that whoever you put it, whether you put it Department of Administration, HHS, or Vermont Program for Quality Healthcare, that they're not just putting recommendations out into the wind, but you're compelling your budgeting entities to act on that. Whether it's to build up primary care or to increase spending on substance use or something like that. They need you want your people who allocate the money to have to point and to want to point to this entity that you've created to say, I got to do what they say. And because otherwise, this is the problem that other states are having. They're identifying what the cost drivers are, but then no one can act on it. They kind of, you've got good evidence, but then frankly, the providers run in and say, oh, no, legislators, you don't understand. Ignore their findings over there. There are all these particular issues. And you don't want to, as legislators, I don't think you want to get caught in that fight. You want to set up a structure so that the evidence is being generated and being acted on, and you oversee how that works.
Yeah, and I think that, to be fair, that should be an independent organization. That's what I imagine they wrote this for. And then to Leslie's point earlier of who's going to hold folks accountable, I think this section to me really speaks to that, because if we want to know whether this statewide healthcare delivery plan is working, we have to be measuring it, right? Measuring our changes. And so that's exactly what this would do. And I think having our regulator doing this in partnership with an organization that's already stood up to look at quality in healthcare in the state, that to me right there, Leslie, is the accountability piece, or enforcement. I think you said it. Thank you.
Leslie, did you have a?
Yeah, so again, thank you so much. I thought I heard you say this, I want to clarify. That maybe we don't need a new because there are two advisory committees, one in section 8 and then another in section 9. And I'm just wondering if you might comment on the need for both of those. Or should they be embedded elsewhere?
I think that's, to me, I think that creates more complexity than you need, and more kind of basis for authority and information. You don't want to have it all in one place. So you don't want to give it all to AHS or to Green Mountain Care Board, but you don't want to have too many. And so two commissions, I read through the legislation. I couldn't quite, the distinction between the two groups wasn't entirely clear to me. I think you have the care board has a lot of authority. So, and it's very high profile. You just, from your standpoint as legislators, I wouldn't think you'd want to create so many different places, so many different pockets for opinions. I think you could, and that's what we were talking about in the previous conversation, is reducing it from 2 to 1, and where would you put it? And we generate a few different ideas: Health and Human Services, separate state agency, the Vermont Program in Healthcare. So I would try to, if I may, I think the monitoring function in 9 is more important than a planning function in 8. And then you talk about where to place that. And I'd look for ways that you as the legislature can give guidance to that entity in number 9 to say, you're going to do more for primary care, you're going to do more for mental health, or something like that. Because the blueprint, I will say, I've worked with the blueprint for a while. It was, when it was first developed, it was very compelling. It was a very comprehensive systemic view. And you have, as I pointed out, just kind of this excellent chassis in the community health centers. I mean, build off your strengths if you're thinking about strengthening primary care.
Can I ask a question? Because hold on one second, Daisy. So you've said twice now, build on our strengths, and I've written down FQHCs, blueprint. What else do you think our strengths are that we should not abandon?
Lose sight.
I was gonna say lose sight of, I'm gonna say throw away.
I'm an unreconstructed regulator, especially in small states like what you have. And I think you've got a lot of really nice levers in the Green Mountain Care Board. I mean, I think you have to give them, you can't give them all the power, and you got to give them stronger guidance so they can say no to, entities when there's evidence that they are expensive. And I think you've got, I know it's been fraught, but I think the opportunity to work with Medicare is too good to pass up. I was glad that you guys pursued a head grant. I understand it's been hard with OneCare, but we're not, the fact that we in the US have so many different payers makes it so hard for our providers, because they're just getting sent different signals and paid at different rates for the same services. And so the opportunity to get aligned with Medicare is just, it's, in spite of your OneCare experience, it's just too big to pass up. It's too good of an opportunity. So I think of that as a strength too.
Daisy?
I was just curious, mental health care has come up a couple of times in here, and there isn't a lot in this bill about mental health care. I was curious your thoughts on that.
Well, this is just my world. I've always paid more attention to primary care than to mental health care, even sort of as I think about Millbank Fund and what we do, because I see it as more, it's hard to say because mental health care is important, but I see it as even more foundational. We need it even before we can shore up mental health, we got to make sure our primary care is strong. And there is evidence, some of it in the health centers, that strong primary care can take care of some, not all, but with the integrated model can do a good job with mental health care. And so I guess my order of battle has always been to build out high quality primary care. Within that, you can take care of less acute mental health conditions. I think the seriously persistently mentally ill needs its own strategy, and that's separate from a primary care behavioral health strategy.
Um, any other questions? I think my last question, and you sort of may have alluded to what your answers may be. If you had to start from scratch and design a healthcare system for a state, where would your priorities go first? Maybe like your top 2 or 3 things.
Cheap primary, cost-free primary care for everybody. At a usual source. So they got to select a place. And when they select that place, it's all free. So it's primary care is a relationship. So they can't go all over the place. They can't, bounce between urgent care centers and emergency room. But if I go to my primary care doc, it should be free. And I would just try to build that out. And that's kind of what comprehensive primary care, that's what the blueprint was trying to do. I'd make That's a very broad question. It's very nice of you to sort of ask that, but I make sure no one goes bankrupt from healthcare. That's kind of what we're doing with the Medicaid expansion. And
When you say no one, you mean a provider or a patient? Sorry.
patient,
Thank you.
yeah. And I would. Maybe that's the way that no one goes bankrupt is something around access to acute care in an emergency room. But I don't think, yeah, it's a really good question. I would almost stop with those 2, primary care and make sure no one goes bankrupt. And maybe the third thing I would put is what you're trying to build here, which is constraints around the whole thing. We have to, like an education budget, we need a budget for healthcare. We need to make sure that it doesn't, that would be my third thing, is we just got to figure out some way to fence this thing. And that's what you're trying to do with the Green Mountain Care Board. It's what they're trying to do with the AHEAD model. We've got to have some way to say, this is all you're getting. We got to live within it. And again, I go back to the education model. That's what we do with education. We allow people to buy up. Okay, if you're really wealthy and you want to go to a private school, you can do that. And so you want to get some services that are not covered, but you want to get your own primary care, sort of a boutique kind of thing. But we got to put some fences around our total healthcare budget. Because I think part of the issue here is that what providers can't get from Medicaid, they go try to get from commercial. That's really been the problem, is those 2 are not coordinated.
Woody, did you have a follow-up?
Well, when you say constraints for the whole thing, fencing it in, aren't you rationing healthcare in the end?
Yes. Everybody
Well,
can't have everything that they want. And it's just a question of who makes that decision.
But there will be those that will get what they want if they have, they have the funds and the ability to do that. It's not fair.
Life isn't fair.
Well, obviously, but
That is the core dilemma, is how do we decide who gets what? And how much inequity can we
Now
handle?
it's pretty inequitable.
And how much are we willing to pay?
Right.
well, maybe we need to pay more.
Did I hear you say that?
Yes, you did.
Thank you so much, Mr. Kohler, for joining us.
Well,
Really appreciate it. Great discussion.
Yeah, I really appreciate the work you guys do. It's not easy, and it's a big unruly health system. So thank you for giving of your time to try to do this work.
Thank you.
Take care.
Here. Elena? First question, design and healthcare system. No pressure, no pressure.
Oh, boy, how long do you have?
Yeah.
Okay. So I didn't prepare anything. I mean, I have notes, I have some high level comments, but I don't have line by line.
Yeah.
I don't have slides or anything, but I'm happy to answer questions and see how it goes. So Elena Barabee, Director of Policy for the Green Mountain Care Board. So I think the board support, I'm here on behalf of the board today, so not as my individual PhD student, but the board supports planning and the creation of the advisory board and kind of the general concepts that are laid out here. I mentioned we don't have any specific line item edits, but I understand there are questions about how HRAP or our Health Resource Allocation Plan interplays with this, so I'll mention that. So maybe I'll start there. So there is, if you look at the way the HRAP statute is written, it's pretty broad and talks about kind of healthcare resources, that would be important. Any questions on HRAP?
I'm still struggling with, and I'm reading our statute on the state health improvement plan, health resource allocation plan. The state health improvement plan is AHS in consultation with Green Mountain Care Board, and it lays out, adopts a state health improvement plan with all sorts of things. And then the Green Mountain Care Board takes over in consultation with AHS and then updates it, posts on its website. There's a million different things that it's supposed to be doing every 4 years. And there's multiple different things that are supposed to be in the assessment. And I'm still struggling to find, other than a few little bit more details, I'm struggling to find what's so different about this that we would create a whole new statewide healthcare delivery plan when it seems like we sort of already have it that might just need some extra details fleshed into it. And also what's going on with HRAP.
I think that's one way to look at it. I think that's certainly one way to look at it.
Am I confused just because I'm confused, or am I kind of on the right track?
Or as opposed to what other way to look at it?
I mean, I didn't write this. I mean, I think if you read the statute, the HRAP statute, like I mentioned, it is quite broad, you know. I think Vermont's critical health needs, goods, services, resources to inform the board's regulatory processes, cost containment, and statewide quality of care efforts, healthcare payment and delivery reform initiatives, and any allocation of healthcare resources in the state. I don't know how you get broader than that. I think the point that I'm making is that it's so broad and we never had staff really to implement all the, the whole framework that you would need to actually make it do that. So we have conducted the analysis. We have, updated that over time. We've tried to make it more interactive and get feedback, but I don't think we've had kind of the capacity to have the stakeholder process, if you will, that's outlined in this bill, or some of the other kind of more pointed details. I think there's a total cost of care target. I kind of read those sections together as being complementary. And so, I would imagine that if you have what the bill, at least how I interpret it, was that you have kind of tying together more of like what we actually have in this state and where we want to go. And then work, I think as Chris Kohler described, how you get there. And I don't think our current statute describes how you get there. It kind of leaves it up to the board to do that the way it's currently written. But I don't, as I mentioned, we haven't had staff dedicated for that purpose. And we've kind of done as much as we can do with it with the staff that we have.
Right. Would the board like more staff?
Always.
Leslie?
Well, if we're going down this road in this bill, 126, does it make sense to repeal HREC? Because it's not, that's a question.
No, it's a great question.
Because it's not adding value.
Oh, I don't think it's not adding value.
Oh, well,
I
maybe
just
that's
think
right.
it's an input to this more detailed vision of the plan, right? So I think if you got rid of the inventory of our health, you'd still need to do that. That work is still necessary. It's part of the.
I guess I don't know that statute very well, if that's okay. And how does it intersect with this? And that's what I don't know where the overlap is and what we hear about redundancy a lot, and we certainly don't want to do that.
I think if you're going to give HS this planning vision, this more detailed view, you could narrow the board's HRAP authority to be more precisely around collecting and aggregating. I think so I think that work is still important. You could transfer that. They would still need it. But I think, you have to think about where you want things. I think there is overlap. And there's different ways of sorting that out going forward. I think you could give the board staff, you could give AHS the direction. I think we're okay with that. There are trade-offs to both of those decisions, but you're still going to need to inventory and analyze what healthcare we have in this state and what Vermonters need.
But go ahead, because like here in section 8, it says gaps in access to care. There's a whole list of things.
Yeah.
And I guess I'm not clear, and maybe I need help understanding how and I'm going to say it again, sorry,
Yeah.
but how these intersect.
So the board right now collects data and identifies gaps in access to care.
Right. And then we're saying this is doing the same.
Right. So that's why I said, yes, there's overlap.
Yeah.
Absolutely. Yeah. So either you take that out,
Take it out of here.
You
and
take it
leave
out
as
here.
HRAP.
and leave the board HRAP, but HRAP, the way it's written currently, the board overlaps even further and still has this broad,
And still doesn't have the resources to do the job.
right, to do more than just that bullet. We're just doing this bullet right now.
Sorry, keep going. Keep going.
Okay, so it's a dynamic series of reports. So, it's not just one report with recommendations at the end. We have a whole website dedicated to compiling and visualizing and describing all of this information. It includes data and reports from many partners, including GMCB, VDH, VAS, NSO, Medicaid, et cetera. So we've been, the legislature established HRAP in 2003, and then you updated your legislation in 2018. So we had it and been doing it for a while, and we do use it, in a broad variety of our regulatory processes, so I wouldn't want to get rid of it. I wouldn't want to totally hand it off, because I think then we would lose some of the, the opportunities to link up what we're seeing and how we do the analysis with our regulatory processes, like CON and hospital budgets. And I think I mentioned we're okay with AHS leading it if there's like this clear delineation. I think, one thing that's could be missing from this plan is really thinking about risk mitigation. So I know Chris Kohler said not a lot of states have this implemented in this robust way, but we did a lot of, we had a lot of discussions with Massachusetts after the Steward Hospital closure, and all of that was a nightmare. Their legislature passed a bill requiring that they do a contingency planning for if there were to be a hospital go into bankruptcy or closure or other essential service loss. So I do think that's not explicitly in here, and those, I'll just let people know we have some kind of, preliminary financial results, and we have maybe more than 6 hospitals with negative, margins again in 25, which is concerning. So I think this is something that, you really want to think about in advance, and not wait till, you have a system-wide collapse, as we are anxiously trying to avoid.
Would the suggestion be to add something like that into section 8 or?
Yes, I think if you're going to be more detailed, making sure that you have kind of, contingency emergency planning as part of that would be helpful.
Thank you.
I would think when you're thinking about, fleshing out the details of how it, how we work together. I mean, I think it should be all hands on deck, making sure that we maintain public process. So the board currently works with a number of advisory groups, and they're also subject to our open meeting laws, and we take public comment. And so I would just, hope that whatever you work with, we make sure that we're, holding the right entities accountable, but also making sure we have transparency where we need it.
Elena, I'm sorry. Apparently we were muted at the very beginning of your testimony.
Yes.
If you could just say your name and your title,
Yes.
and also what HRAP is.
Oh, yes. I am Elena Barabee, Director of Health Systems Policy at the Green Mountain Care Board. And HRAP stands for Health Resource Allocation Plan, and it is one of our statutory duties.
Thank you.
Yes, thank you. Okay.
Any questions? Yeah, Leslie?
Well, I'm looking at this list of members on the advisory committee and, advisory committee, the healthcare delivery advisory committee, it's a lot of people. It's A through or D through whatever. Is there anyone else? I mean, is there a contingency if we miss some? I mean, what if we miss them? Is there a process to add?
I mean, I think if you have a public process and you make sure there's public process around this, any number of interested parties could participate. So that might be one way to deal with that, because I don't,
Some other interested parties might
have
be
other-
language.
Yeah.
Okay, thank you.
I count 14.
Yeah, it's a lot of
That's
but
strangled.
it's a lot of, it's very specific, and what about if we didn't think about whatever?
Well, I was thinking that maybe there are too many participants to make decisions.
I think, is this group making decisions, or is this
Sure.
group advising, and is it a consensus process?
Yeah.
Or does everyone get to write their
A vote,
dissent?
is it?
I think there are
democracy?
questions about how this would work.
There
And what
wasn't a
you,
question of
yeah.
who we left out, but
how you get it done.
yes, and maybe such a large grouping is too much.
Or is that a rule? I mean, not the number of people, but how it gets it done. I mean, there are 11 in here and we do pretty well. So 3 more is a bit equal, but.
It's never a meeting.
Depends on who you ask.
Well, my question around anytime we form these advisory committees is, are they serving healthcare delivery, or are they representing the 14 different?
That's what I think. That's why I'm worried
Or are
about
they
it.
doing anything?
I'm sure they're working very.
I'm sure they are too, but
And I would just point out too that, you know, what is the lift of this group? Making that clear, because I think a lot of the work that is asking them to do is stuff the board has done before, you know, like that we didn't, the total cost of care targets was done at the board under the previous all-pair model. We kind of tend to do that work and support our partners at AHS in their negotiations of the AHEAD model. So I think understanding that if you add more work to this group, that it could end up being unfunded work at the board, if we're not really clear about that. So I just.
My concern is if we don't do this, or however, whatever information it ends up being, so much else in this bill is built around this statewide healthcare delivery plan. And so we would have to have some guidelines. Anyways, any other thoughts?
I think the only other thing is thinking about where do you need legislation and more detail versus holding entities accountable for the work they're already tasked with doing. And then, you know, asking maybe hard questions if we're not delivering, I think, and then asking us why, you know, and I think we can come back with, you know, some, you know, if it's a staffing problem or if it's a technological, you know, whatever it is, we can work through that. But I think thinking about what's legislation versus what's kind of pushing us to be accountable to deliver what we've already set out.
Leslie?
Am I missing this, but I don't see any reporting back to any committees back on this healthcare delivery advisory committee. Where is that?
Seems like 10 sections in the back there about reports back. And
Well, there's a whole separate section about that. Section 14. But that's the board's implementation of this act. So does that mean the board is responsible for the advisory committee's work?
So on page 21, line 12, the agency shall present the plan to us and health and welfare.
About the results of the implementation of the plan.
What is it that you're looking for specifically?
I think that one of the things that came up and I meant to ask Chris Kohler about was, you know, we had been talking a little bit about primary care and maybe a primary care commission and that. But should there be a yearly reporting, you know, very specific reporting on the status of implementation?
is that section, page 28, section 14?
Well, that was confusing to me because it says this act. But I'm not sure what that, does that also refer to that commission? Or let me get the right word.
I would assume that it would be that they report back to
Who's
us
the
on everything that they do.
advisory committee?
It's in this act.
Well, who does the advisory committee report to? Yes, definitely.
I'm sorry, I'm so engrossed in trying to find it. I didn't look over.
At Kirby Office of Legislative Counsel, there is not a specific reporting requirement for the advisory committee. They are providing ongoing advice. And they're providing coordinated and consensus recommendations to the General Assembly. But there is not an annual reporting requirement. It's chaired by the Secretary of Human Services or designee. I think that's some of your accountability is to ask that person for an update. But there's not an annual written report or reporting requirement. You can think about whether you wanted one or, and also whether that is the best use of the advisory committees.
Well, we're not asking for a product, right, from the advisory committee, and that's what's confusing me a little bit. I mean, they could sit around for years, and I mean, I'm being a little cynical, but whatever.
No, we are. They update the plan every 3 years.
Well, 3 years is a long time in this healthcare world right now. So I'd like to add that to a, opportunity for conversation.
Wait, does the advisory committee update the plan every 3 years? Or does it, no, AHS does.
Well, the advisory committee is informing AHS so I'm a little confused.
I'm a little confused as to what exactly what their task is.
I agree with that.
You want to walk through the language?
Thank you.
We could, yeah,
Well, as long as Elena, like,
let's have Elena finish and
yeah.
then.
I think I was gonna open it to you for questions, so if you wanna transition to language, that's fine. Yeah, okay.
Anyone have any questions for Elena? Thank you. We'll do a quick refresher.
Me too. Which one you doing? The old model.
That it's introduced and
No. Okay. They want to look at all the official.
So we'll just do a walkthrough of what they're supposed to do.
Does it help to walk through sections 8 and 9, since that's where Vicky just went in?
Right, it's been a couple of weeks.
Yeah. Books in the air.
Yeah, before I, it felt so good.
Opening the door makes a big.
You leave that door, why don't you get out of the way? So.
Yeah.
Give it another minute.
Good afternoon, Jen Carby from the Office of Legislative Counsel. So just orienting us a little bit. We have been talking about S-126 and Act relating to healthcare payment and delivery system reform, and specifically sections 8 and 9. So let me just there. So it starts on section 8 starts on page 18. This is the statewide healthcare delivery plan. Does it make sense to walk through them both?
Yes, sir.
Okay, so the statewide healthcare delivery plan starts out with the Agency of Human Services in collaboration with the Green Mountain Care Board, Department of Financial Regulation, Vermont Program for Quality in Healthcare, Office of the Healthcare Advocate, the Healthcare Delivery Advisory Committee that we will see in section 9, and other interested stakeholders. Shall lead development of an integrated statewide healthcare delivery plan as set forth in this section. And the plan is supposed to do a number of things. It's supposed to align with the principles for healthcare reform that are in section 9371 of Title 18. Plan shall promote access to high quality, cost-effective acute care, primary care, chronic care, long-term care, and hospital-based, independent, and community-based services across Vermont. Strive to make mental health services, substance use disorder treatment services, emergency medical services, non-emergency medical services, and non-medical services and supports available in each region of the state. Provide annual targets for the total cost of care across Vermont's healthcare system and include reasonable annual cost growth rates while excluding from hospital total cost of care targets all revenue derived from a hospital's investments in primary care, mental health care, and substance use disorder treatment services. And using these total cost of care targets, the plan shall identify appropriate allocations of healthcare resources and services across the state that balance quality, access, and cost containment. Also directs the plan to establish targets for the percentages of overall healthcare spending that should reflect spending on primary care services, including mental health services and preventive care services, which targets shall be aligned with the total cost of care targets. Plan is supposed to build on information and data and information from the Act 167 transformation planning work, the expenditure analysis and healthcare spending estimate,
developed pursuant to an existing section titled 18 VSA 9383. The State Health Improvement Plan adopted pursuant to 9405 subsection A of Title 18. The Health Resource Allocation Plan we were just talking about, published by the Green Mountain Care Board in accordance with statute. Hospitals' community health needs assessments and strategic planning conducted in accordance with statute. Hospital and ambulatory surgical center quality information published by the Department of Health pursuant to section 9405 of Title 18. The statewide quality assurance program maintained by the Vermont Program for Quality Healthcare pursuant to section 9416 of this title. And such additional sources of data information as the board, agency, and department deem appropriate. Some of that language is a little bit left over from an earlier version that had the board and others in charge. Then we get to plan must identify gaps in access to care, as well as circumstances in which service closures or consolidations could result in improvements in quality, access, and affordability. Opportunities to reduce administrative burdens, such as complexities in contracting and payment terms, and duplicative quality reporting requirements, and federal, state, and other barriers to achieving the plan's goals, and to the extent feasible, how those barriers can be removed and mitigated. Directs the Green Mountain Care Board to contribute data and expertise related to its regulatory duties and its efforts pursuant to Act 167, and the Agency of Human Services to contribute data and expertise related to its role as a state Medicaid agency, its work with community-based providers, and its efforts pursuant to Act 167. And then there's the timing provisions from 2025 through 2027. The Agency of Human Services shall engage with stakeholders, collect and analyze data, gather information obtained through the processes in Act 167, and solicit input from the public. In 2028, the agency will prepare the plan, and by January 15th, 2029, the agency will present the plan to this committee and others. And it requires the agency to prepare an updated plan every 3 years and present it to the General Assembly on or before January 15th every third year after 2029. That is the statewide healthcare delivery plan before we get to the advisory committee.
I have a question about this section. Can I ask it now before we go to the next section?
Sure. Do you have a question for Jen?
Yeah.
Or just a question, Jen?
I think it's something Jen could answer
Okay.
better than any other witness, no offense to anyone, because it has to do with Vermont law.
Okay.
The way that this is the way this language is written, do any of these, what do they call them? It's like in subsection D where it says, they shall engage with stakeholders and like use information from I went too far ahead. It's where it lists all the things they should, here we go. It's number 5 where it says build on data and information from. Is there anything there or in this section that ties the proposed plan with the current principles of Act 48 that are in existing statutes?
Yes, that's the very beginning, is that the plan must align with the principles for healthcare reform.
Say that?
Page 18, B1, the plan shall align with the principles for healthcare reform.
All right, so section 9371 is where that is.
Yes.
Okay, thank you. That I probably could have looked it up, but I figured I'd ask you. It's sitting there. And then the other thing is, the way this is written, it's vague in terms of the settings. Like it talks about the kind of care, like mental health, substance use, emergency, and it talks about, I guess it does say acute care, primary care, but it doesn't say, and it does even, I guess it does even say something about home-based, but here's what I'm getting at. Where does corrections fit into this? Because isn't there an existing Vermont law that says that incarcerated individuals get access to the same healthcare? They should get access to the same healthcare that they would get outside, but they don't. So I'm wondering, how does
I don't know how corrections fits. I would have to look into, I don't know if other folks from IC Brendan, so I don't know if that means you have an answer. But I would have to look at it. I know there is a requirement for the state to provide healthcare services to people who are incarcerated, but I don't know how it aligns with what we provide to individuals not incarcerated. I'm
So I
not sure
guess-
I'm not sure there's a specific requirement around that.
My request for later would be, we take testimony on that and that this plan be for everyone, regardless of their setting. Because I think there's opportunities for saving, I'll get into this more later, but like we spent there up to 40 million on a contractor. What if we dump that 40 million back into our system of care and just have the community-based services integrate? So we can get into it more later, but the way this is currently written, it doesn't specifically say corrections, and I just want to make sure we have time to consider how healthcare and correctional settings fits into the overall healthcare system. That's all.
Okay,
Thank you.
Yeah.
thank you, Brian. Leslie?
Thank you, Jen. That was incredibly helpful. I didn't see that piece, which is sounding like it's going to take 3 years to have a plan, which makes
Well,
me,
that's what's in here.
that's what's in here, and that makes me, 4 or
3.5.
3.5, whatever. That's a long time. We just heard that maybe 6 hospitals are on the brink, like now. So, and this isn't necessarily for you, and I'm not sure this came up before, but I'd like to hear about an emergency.
And I think you're naming sort of the tension of the moment we're in too,
Yeah.
which is how do we thoughtfully plan for where the healthcare system goes while addressing the crisis that is here right now?
And is that part of this bit? Or is there other places where we're thinking about this? Or should we really get going on that here?
Well, can we do both?
Yes, we can.
And I'm not sure that this vehicle necessarily can address the immediate. I think that there are other vehicles that may be. But I hear you and I am thinking that all the time.
And I think one of the other questions too is what, and as far as addressing the immediate situation, what requires legislation and what does not, you know, what aspects of it are a legislatively addressable solution? And what is happening or needs to happen regardless of what the laws are that are in place. I mean, I think there's a lot of care delivery that is not beholden to what the legislature passes, and what does that look like?
So how do we find out about that? The reassurance of companies?
Well, I think Chris had mentioned something that I had jotted down, but essentially maybe the reason that we're in the situation we're in right now is because we haven't been doing this previously. And so maybe this is imperative that we do this so that we have a path and that we're going somewhere down a path. But that doesn't mean that we don't have urgent needs as well. But we can't abandon this because maybe that's why we're in the situation we're in now.
Never suggested abandon this for sure. More so, how do we do both? Yeah, both act.
Yeah, both and.
Yeah.
Okay.
Okay, now we get to the advisory committee, section 9. And this creates the healthcare delivery advisory committee, and its tasks are to establish affordability benchmarks, including for affordability of commercial health insurance, evaluate and monitor the performance of Vermont's healthcare system and its impacts on population health outcomes, to collaborate with the Green Mountain Care Board, Agency of Human Services, Department of Financial Regulation, and other interested stakeholders in developing and maintaining the statewide healthcare delivery plan. Again, it may need to be modified to reflect changes that happen later in the process. Advise the Green Mountain Care Board on the design and implementation of an ongoing evaluation process to continuously monitor current performance in the healthcare delivery system and provide coordinated and consensus recommendations to the General Assembly on issues related to healthcare delivery and population health. There are 14 members. I don't know if you want me to go through them or not. Okay, great. Skipping to the end here, Secretary of Human Services or designee is the chair, and the Agency of Human Services provides administrative and technical assistance to the advisory committee.
Just for my own, is there anywhere else it's a little A1 establish affordability benchmarks, including for affordability of commercial health insurance? Isn't there other places in the bill that tasks somebody else with? Are we asking for this advisory committee to actually set
And fairly close to the end, I think there was some interest if there is an expectation that various players in the healthcare system are striving for affordability, what it means for something to be affordable. So specifically around, part around affordability of commercial health insurance. But there may be some room for refinement in that.
Is it in the statewide healthcare plan too?
Affordability benchmark.
Leslie, and then I want to take a break before we move on to our next witnesses.
Well, I think you asked a really important question, is like in 9 and, little a 1, 2, 3, where, is that going on elsewhere? Do we need a new, to figure out who's going to evaluate and monitor the performance of the system? Don't we have people doing that in Green Mountain Care Board?
I'm just wondering if these 14 individuals are the best people to decide what affordability is.
A bunch of herding cats.
Go ahead. No offense to, because I know
Anybody
a
here.
lot of the 14 people. What's the cancer? Brian, and then we're going to take a break.
It just made me think about herding dogs.
Oh.
Sounds more fun. So,
Easier.
and cuter. So I'm starting a fight with the cat people. It's not, okay, so this might be a really small technical thing, but do we know if this is gonna have to be looked at by GovOps? Because it's gonna be a standing body? Because sometimes when we create a new board or commission or something, they have to review it and then they'll change the membership after we spend a lot of time on it. So I guess what I'm getting at is before we spend many, many, many days taking testimony on who should be on it and change it. And that I just want to make sure it's not going to go to another committee that's going to completely change it, because that always frustrates me. Like when we spent weeks on the suicide prevention bill and then judiciary just gutted everything we did in one day. Just flagging it as a process.
That's a great question, and thank you for flagging that.
Yeah, we don't have to know that.
And none of these people are paid. The only thing is that AHS offers administrative technical support.
Yep.
It takes them
Having a
out,
hard
so
time
I'm assuming.
understanding how this group can establish affordability benchmarks, including the affordability of commercial health. I don't get it. So I'm missing something.
Something to discuss. Okay,
Sorry to
one of the
interrupt.
14.
Yeah.
Sarah Teachout with Blue Cross and Blue Shield of Vermont. The Green Mountain Care Board last month adopted affordability guidance for commercial health insurance. So this is a little redundant of what's already.
That's what I'm wondering, yeah. I think we need to understand that, yeah.
Okay,
Can I say something
yes.
about your comment, Brian, about it going to other committees? They would only be changing things that are within their jurisdiction, hopefully.
but they would only be looking at this piece. But they would be able to say, no, we don't think these people should be on it, or we do think these people should be on it. Or, no, we don't think it
It
should.
doesn't strike me as something that specifically would need to go to the Government Operations Committee. It's not establishing a new sort of, it's establishing only an advisory committee that has no official role in state government. So I would be, the only things that go by operation of rule are the money bills, bills that go to Ways and Means and Appropriations. Everything else would have to be either requested or actively referred. So I would be surprised if this went to GovOps specifically to look at the membership of an advisory committee and help.
Thank you. Okay, so let's take a break. Back at 3:00.